Okay, hello everybody. Just before we kick off, I'm just keen to know whether all our participants can see and hear us okay. If you can see and hear us okay, there's a little chat box on the bottom left-hand side of your screen. If you can just type a little message there to let us know if you can see and hear us, that would be a great help. Okay, someone can see us? Can someone see and hear us? Excellent. Wonderful. Okay, I think we're doing pretty good. That's great to hear. Wonderful. Okay, well, we'll just kick off in about a minute's time. We'll just wait for a few more people to log on. But that is marvellous that people can see and hear us because this is the first time we've used this platform. So I'm hoping that there's no little glitches, but so far we seem to be all okay, which is really exciting. Okay, so yeah, we'll just wait another minute or so. At the moment, we've got about 15 or so people who've joined us for the webinar. We'll see if a few more people log on. Yes, this webinar is actually currently recording at the moment, and at the end of the webinar, we'll upload the recording onto the National LGBTI Health Alliance website in the Knowledge Hub. I'll probably do that later this week, probably within a couple of days. So if you can't stick around for the whole webinar, or if you'd like to share it with your colleagues, you can do that later in the week with a URL. And we also can share copies of the slides with people as well. So we can do that at the end of today's presentation. Okay, well we've hit the hour or half hour, depending on where you are in Australia. So I think we might kick off. Thank you everyone for joining us today for today's webinar. My name is Sally Morris. I'm the National LGBTI Mind Out Project Coordinator with the National LGBTI Health Alliance. Today we've got Jeremy Wiggins here with us, who works at the Victorian AIDS Council in their drug and alcohol projects, and he's going to be talking all about drug and alcohol use within LGBTI communities. So before I hand over to Jeremy, just to acknowledge the traditional owners on the land in which we're meeting today. There can be lots of different places all across Australia. I'm currently in Brisbane, so I'm on Jagera and Turrbal land, and Jeremy's currently in Victoria, in Melbourne. So do you know who your people are there?
The Wurundjeri people of the Kulin Nations.
Awesome, lovely, thank you. So actually I'm going to hand over to Jeremy, and so I'm going to disappear, and hopefully, fingers crossed, everything goes well today. Just to remind people, if you want to ask Jeremy any questions throughout today's webinar, he'll probably be answering most questions at the end of today's webinar, but you can, as you go along, type questions in the text box, which is on the lower left-hand side of your screen. As I've already mentioned, today's webinar will be recorded, so you can go back and re-watch and share with colleagues as well, and we'll make that available in the next couple of days. Okay, so I'm going to hand over to you, Jeremy, and fingers crossed all goes well. If you have any issues, just type us a message. Lovely, thank you.
Thank you, Sally. Hi, everyone. I'm Jeremy Wiggins, and I work at VAC, which is the Victorian AIDS Council, and my role there is to lead the projects in the alcohol and drug services, but also I lead trans health as well. And today I'm going to be talking about the prevalence of alcohol and drug use in LGBTI communities and some of the underlying risk factors and reasons as to why LGBTI people may engage in drug and alcohol use and how it can become problematic, but also link you and sort of go over some of the resources that we have developed, that harm reduction resources that support our communities. So just briefly, a little bit about VAC, if you don't know who we are. We are the Victorian AIDS Council, and we're a community organisation that was established in the early 80s in response to the AIDS epidemic in the early 80s. We offer a range of services to people living with HIV, sort of care and support services, as well as we have a general practice clinic. We have rapid HIV testing. We also have a trans health centre, peer-led trans health centre called Equinox. We also offer counselling services, so we have psychologists and counsellors. And aside from that, we also have an alcohol and drug service. So a couple of years ago in Victoria, the drug and alcohol reforms occurred, and there was some recommissioning of that sector. And throughout that process, VAC was able to pick up a couple of catchments to actually run alcohol and drug services. And what's different about the kind of agreement that we have with the state system is that we are able to only see LGBTI people. So we actually have 3 alcohol and drug counsellors, and we have a care and recovery coordinator providing direct services to LGBTI people and people living with HIV, also people living with hepatitis C. So we are very busy, and we're about to talk about why. So this is, I guess, a bit of a snapshot around the prevalence of alcohol and drug use in LGBTI communities. And so this is a meta-analysis of a range of evidence and research that exists that looks into what drugs are our communities using and members of our community, and what is the context of use. So alcohol is still, is the most frequently used drug, for all populations in Australia. And so not surprisingly, it's also the most commonly used drug for LGBTI communities. Also, the highest rates of alcohol use disorders, or higher rates of alcohol misuse, is actually found in lesbians and bisexual women. And there's also some great research by Dr. Ruth McNair, which was funded by the Beyond Blue, called the ALICE study, that actually looked into help-seeking behaviours of bisexual, queer and same-sex attracted women who were experiencing issues of alcohol use. And sort of some findings that came out of that study is that queer or lesbian, queer and bisexual and same-sex attracted women generally don't engage in alcohol and drug services for an alcohol drug issue. They're more likely to seek a private counsellor or therapist for a range of other issues. So it might be a mental health issue, or perhaps relationship issues, or something else that's going on for them. And usually, they would see their alcohol use as something not significant or impacting a range of other areas of their lives. So that was interesting in terms of help-seeking behaviours, but also another reason why they didn't engage in mainstream health services is because of the poor service that they had actually received around it being insensitive or not best practice. So these are the sorts of encounters that can occur that influence people's help-seeking behaviours. There's also higher rates of tobacco use in the LGBTI community compared to the heterosexual community. That is also, again, higher in terms of lesbian, bisexual and queer women. There are incredibly high rates of smoking, particularly in younger lesbian, bisexual and queer women. And our sister organisation, New South Wales ACON, have a great campaign that they launched earlier this year around stopping smoking. So go check out ACON's website for that. There's also higher rates of illicit drug use in LGBTI populations compared to the heterosexual population. And we'll talk a little bit about which drugs and what's the context soon. There's higher rates of depression and suicidality, particularly for transgender communities. There's research in Australia and globally that speaks to the higher rates of poor mental health of transgender populations. But at VAC, we probably about 70% of our clients are men who have sex with men. So MSM we use that term for men who have sex with men because not all men who have sex with men may identify as gay. Some clients might be in heterosexual marriages with kids and also engaging with sex outside of the relationship. So that's why we use that term, MSM. And the most prevalent substances in that client group is actually alcohol and methamphetamines. So we find that in the cohorts that we're mostly seeing come through are men who are having sex with men who are having issues with methamphetamine. So that's why we have developed particular programs to try and address that. So this is, sorry, I can see some questions coming up. Does that include trans women? Okay, good question. So a lot of the research around, so the question is, does that include trans women who are lesbian, bisexual, and queer? I'd probably say that it doesn't. Research is still looking to improve in terms of its data collection and how gender is captured in terms of those particular cohorts. There are some research studies like Private Lives 2 and a closer look at Private Lives 2 out of Gay and Lesbian Health Victoria that does actually look at the prevalence of drug use with transgender women, particularly high rates of marijuana use. But not all. You really have to analyse and investigate each research study to see how they have captured gender identity and to see if they're distinguishing between cisgender, which is someone who isn't trans, and someone who is trans. So sometimes they might still capture trans women or trans men as men or women, but unless they're really clear around how they're collecting that data, it's difficult to sort of make assumptions around that. So drug use with gay men compared to heterosexual men. So this slide here compares data from two studies. One is the National Drug Household Survey, and another is the Gay Community Periodic Survey, which happens every year in both in major capital cities. So the blue is gay men and the red is heterosexual men. So you can see already that gay men are towering over heterosexual men in terms of use with cannabis, amyl, ecstasy, amphetamines, crystal methamphetamines, and cocaine. And what we can sort of see here is that, I mean, apart from cannabis, of course, but a lot of the other drugs that are used at higher rates are actually drugs that are used they're uppers. They're used in terms of a party scene or to increase social engagement, or potentially also to enhance someone's sexual experience or sex drive. And these are the range of scenarios or contexts as to why some of these drugs might be used. So we do see men who have sex with men using more kind of party and interactive substances that increase engagement and drugs compared to sort of more of the downer type drugs. So this is also looking at HIV positive men compared to HIV negative men and methamphetamine use. So it's looking specifically at meth use here. And we can see that the red line represents HIV positive men and the blue line represents HIV negative men. So this is coming out of the Sydney Gay Community Periodic Surveys from 2008 to 2013. But the stats are very similar to Melbourne. I mean, there's not much difference between Melbourne and Sydney in terms of the two research studies. And the reason why HIV positive men are using meth at higher rates compared to HIV negative men is largely due to the trauma experience with receiving a new diagnosis of being HIV positive. And also the stigma and discrimination that occurs still around living with HIV. So that's some of the similar reasons why LGBTI people are more likely to be using drugs. We can see with being perhaps a gay man and also living with HIV is increasing those risk factors around poor experiences and increases the risk and chances of I guess engaging or experiencing problematic drug use. This is a bit of a snapshot around same gender attracted women compared to heterosexual women. So again, the two data sets here being compared one is the National Household Drug Strategy Survey from 2010, which is in red, so that's heterosexual women, and the blue represents lesbian, bisexual, and queer women from the survey, the Sydney Women and Sexual Health Survey from 2010. So that is a survey done only in Sydney, and you can see here that the highest drug being used with same gender attracted women is actually cannabis, but also alcohol is right up there. And what we find is that the research sort of says that, yes, lesbian, bisexual, and queer women are using drugs like meth and speed or amphetamines, ecstasy, but it's more likely to be cannabis and alcohol, and that might be because of the differences in the ways people socialize, and also around intentional environments. So what we've seen over the last few decades is a decline around the number of venues and parties for same-sex attracted women or queer women, and also other factors contributing to people's access to drugs would be their socioeconomic status, and men are more likely to be employed and having higher incomes compared to lesbian, bisexual, and queer women. So these are a range of factors that might influence how the types of behaviours and drugs that people might be using. So this is I'm just going to talk briefly about what these risk factors, drivers and vulnerabilities are that might lead to problematic use. And obviously the LGBTI people, they have the experiences of being LGBTI, but also they may have a whole range of other experience not related to being LGBTI, and compared to just like the broader population may have experiences that might lead to problematic use, and that might be something like grieving the loss of a loved one, perhaps losing a job, or a range of other scenarios that don't necessarily discriminate on the person. But in particular to LGBTI people, there are a range of specific experiences that the broader heterosexual or cisgender population may not experience unless they are also part of a stigmatized minority group. So some of these concepts, I guess, are internalized homophobia and transphobia. And this is actually a really common recurring theme. We actually have support groups and therapeutic groups at VAC to work with people around these specific issues, because, and that's the concept of, we are living in such a heteronormative and cisgender normative world where that's a dominant narrative, where we grow up experiencing messaging left, right, and centre that is homophobic or transphobic. And I guess that's the point where people start to internalise these beliefs and take them on. So are living daily with these own thoughts about themselves. And that can be something that needs to be unpacked with the client when working through their own internalised homophobia or transphobia. Also, the experiences of coming out. The coming out is a bit of a contentious term. It's not necessarily an affirmative type language. I think we're still trying to find new language to talk about when someone discloses or declares that they are either LGBTI. So what we use in terms of trans communities is more like affirming one's gender, or you could use affirming one's sexuality. But in terms of coming out, that's an experience that some people may do once in their lives, but often it's the case that has to happen in a reoccurring context, particularly with transgender people and intersex people having to tell medical providers or GPs on a regular basis that they might be trans or intersex, and that be a source of pain, or if it's met with inappropriate responses or hurtful responses, again, this can be creating underlying levels of trauma. Also, rejection from family is definitely an isolating and painful experience that can cause, sort of issues for people throughout their lives, and also a general lack of social connection. So if people are isolated, finding it difficult to socially engage and connect with people, with peers who are displaying behaviours that are not necessarily engaging in problematic alcohol and drug use, that can also be an issue for people in terms of not having a positive, healthy framework of social connection. So, as well as mental health. So LGBTI people have higher levels of poor mental health compared to the broader heterosexual population. And certainly from a dual diagnosis perspective, and certainly with clients coming into our services, Certainly with alcohol and drug use, it can often be closely linked to experiences of poor mental health, and sometimes you need to treat both mental health and alcohol and drug use at the same time with a multidisciplinary team, and that's why we have a care recovery coordinator. So certainly issues around anxiety, depression, bipolar disorder, and personality disorders, or any other kind of mental health issues or mental illnesses may be impacting the risks around alcohol and drug use. So in terms of discrimination, so this is discrimination that could be experienced in the workplace, or more at a more systemic level. Like right now, we're living in a political climate where marriage equality is being debated, and often in ways that is quite detrimental to the health and well-being of LGBTI communities. And this type of environment, as public as it is now, is probably going to be an even heightened level of poor impacts on people's mental health and experiencing that type of discrimination. But also discrimination can happen, in experiences of just accessing bank services or any other range of goods and services. And these sort of daily experiences can actually cause, what goes on to the next point, this experience of minority stress. So minority stress and incremental trauma, these are terms that do translate to other minority groups and marginalised populations around the world. I think minority stress is actually a term that was coined in the USA through the experiences of Black African Americans and their experiences of racism, which is an ongoing daily experience multiple times a day throughout the course of their lives. So that minority stress experience is the idea of, as well as incremental trauma, is the idea of from birth, there's these regular experiences on a daily basis or multiple daily bases. It might not be a significant extreme event such as violence or assaults, but it could be more just the slow erosion of someone's sense of self, or continually telling that person that they are not right, the way that they are, the way that they identify. And so that low-lying level of stress is a constant build-up over decades, and that can actually cause instability and a range of risk factors around alcohol and drug use, because often the reason why people engage with alcohol and drugs is because at first it feels good. It takes away the struggle, it takes away the pain. It's a form of sort of lubricating a social sense or boosting someone's self-esteem or confidence, and then it can perhaps turn to self-medication or perhaps reducing anxiety, experiences of minority stress. And usually then if it is habitual use, it can actually start to cause a range of issues. So there's also the term heterosexism, and I mentioned before living in a heteronormative world. So that's the experience of living in a world where you're constantly reminded and told that being heterosexual is the norm, and so that again that can impact people's sense of being able to belong and connect to a range of environments and groups. But I guess one of the biggest things, now we've talked then about like a range of issues leading up to why would someone be in a context of engaging in problematic alcohol or drug use. And if we look back over the last 20, 30, 40 years or even before that, it used to not be very safe to be out and about and be trans or gay or queer or anything like this. And people used to experience direct violence, and it was unsafe to be seen holding hands or engaging in social scenarios with people. And that sometimes that violence even occurred directly from the police. So over the last few decades, we've seen, if people wanted to be engaging and finding community or finding a partner, a boyfriend or a girlfriend or a lover or friends, that kind of had to occur in sort of scenarios that involved going to a bar or going to you're basically going to a bar, going to parties. So that source of connection and belonging always was occurring around the use of alcohol and drugs. And that hasn't necessarily been a negative thing for people. There's also research that suggests that these sorts of environments can actually create a positive sense of connection and a lot of learning that can occur and a lot of bonding that can occur with people. But we need to be talking about also what are the signs of problematic use and when is that actually causing harm. So the normalization within LGBTI social culture is also an issue for it being difficult for people to engage in social scenarios where alcohol and drug use isn't present. So that sort of gives people an overview as to what some of the underlying reasons might be specific to LGBTI people. But again, if you were to talk about other experiences that all people might be vulnerable to, such as grief, loss, history of trauma, sexual abuse, physical abuse, and a range of other issues. This is more talking about LGBTI specific experiences and how that might even compound further on top of other experiences of trauma or stress. So I'm not going to read through all of this, but this is actually something really interesting to look at. If you're wanting to look at more research, I'd recommend looking at a closer look at Private Lives Too, which is from 2015. And that really, again, just reinforces the experiences of heterosexist discrimination and also the normalization of drug use on the commercial gay scene, and how these experiences can certainly increase the risk and prevalence around problematic alcohol and drug use. So that sort of gives everyone a bit of a background information, or sets the foundational scene of what kind of drugs LGBTI people are using, why might they be using these drugs, and so what we did, we developed a harm reduction resource to engage with the community, to start to have conversations and dialogue, and to equip the community with tools to be able to assess, is their alcohol and drug use becoming problematic, and what does that look like for them? Obviously, in our service, it's very person-centered. We certainly don't, wave our fingers and tell people to stop using drugs or alcohol. We work with where they're at. We work with what they want to achieve. What are their goals with their alcohol and drug use, with their recovery? Is it to reduce use? Is it to control their use? Is it to stop their use completely? We work with what they want to be working on. And so we produced this resource in partnership with the Alcohol and Drug Foundation and the Australian Federation of AIDS Organisations, and it's called touchbase.org.au. And if you want to log on now and have a look, or after this webinar, feel free to. So Touchbase, it covers a whole range of information. It covers information on alcohol and drugs. What are the drugs? What are the impacts? What are the side effects? What are the long-term effects? Also mental health. So how do drugs interact with my mental health? How do drugs and alcohol impact my brain? If I'm feeling low, what can I do to improve my health and well-being? If I'm feeling shaky, how do I improve myself? How do I stay well? So it's a range of tools for people who are experiencing low mental health as well, so poor mental health. People who might be self-harming, what are some other strategies that they could do if they're self-harming that might not leave leave them inflicted with injuries? So there's a range of other self-harming tools that they could use. So look in detail to this. I know that I'm talking very broadly about it. There's also a lot of information on sexual health, so STIs and HIV. And in that section around sexual health, it has a lot of information on sex and drugs, because often with LGBTI people, in particular gay men or men who have sex with men, sex and drugs using drugs with sex can occur at the same time. So that means that there's a whole range of other scenarios and considerations in reducing the harms associated with drug use and reducing the risks associated with sex. And that's an important page to really look at when working with clients who might be using meth and having sex. Is affecting their judgment. Are they aware of PrEP, which is a daily pill that they can take, which will prevent HIV? So there's a whole range of other harm reduction and risk reduction tools and strategies that people can use. And it's also got a toolkit, which is the section where people can go into and assess their use. So they can fill out surveys. If they're planning to use or planning to party, how do they do that safely? So what does safer drug use look like? And so it's getting people, if they're going to be using drugs, we can't necessarily stop them, but we can speak from a harm reduction perspective and equip them with tools and strategies and as much information and education as possible to reduce the harms and to keep people safe and well. So why we did that is why we created Touchbase is because there was a real lack of MSM, LGBTI, and people living with HIV-specific alcohol and drug harm reduction resources in Australia. In fact, globally, there is a lack in credible, current and contemporary tools in that area that reflects the language of the community and the needs of the community. There's also a lack of local sex-positive evidence-based resources that reflect current trends around drug use with men who have sex with men, so i.e. methamphetamine use and GHB. So this is language that in the community where people might refer to as P&P, which is party and play, where people are actually accessing, sex through online apps and looking for hookup partners that are interested in using drugs. So for sex. So we need to reach out to these communities as well and to make sure that we're tailoring this information that speaks a language that they find engaging. There was limited accessible information on drug interactions with other commonly used medications in the LGBTI community. So that is not only people living with HIV who would be hopefully on HIV medications, but also trans and gender diverse people who are using hormones and intersex people who are using hormones. If people are, for example, on estrogen or testosterone, or they're on a HIV medication, they can go to Touchbase, and if it's clinically known and then there's evidence to suggest that there's a known interaction, it will pop up. And I'll show you a little bit later what that looks like. Because there was also a lack of resources that holistically look at risk factors that may lead to problematic drug use, poor mental health and sexual risk-taking behaviours, and how these all intersect. We understand that people's lives are very complex and things can be all intersecting, and a scenario around there being poor mental health, low self-esteem or low confidence or a history of trauma leading to problematic alcohol and drug use and engaging in sexual scenarios that are risky could be, risk factors that lead to HIV diagnosis. So it's important that we look at this holistically. So while developing Touchbase, we asked the community what do they want to see out of a resource that's for them. They wanted to see easy, understand language that was relevant in illustration and in relation to the content. They wanted to see reality in the website. They didn't want it to have a tone of authority. They want it to be on their level. They wanted to acknowledge that people are going to take drugs and to participate in a variety of sexual practices or lead to different sorts of lifestyles. So that means that they didn't want to be judged for that. So it's really important that the tone of Touchbase was non-judgmental and non-stigmatizing around their sexual behaviors, around their gender or sexual identity, around their drug use or their HIV status. And they wanted a use of imagery that appealed to the demographic and language that was appropriate to the subject matter. So we didn't try to be too cool with this website, but we just tried to meet people where they're at and reflect where they're at. So the process of this was, VAC, because we are an AOD service provider and we have that community credibility and engage with the community, we were able to, do community consultations and also had that direct clinical experience in working with this community. And by partnering with the Alcohol and Drug Foundation, which is formerly the Australian Drug Foundation. They had the research and evidence base, so they did content review. They have national alcohol and drug credibility. They provided all of the evidence and all the literature, which we were able to just apply an LGBTI language lens over. So they were very helpful in this process. And then the Australian Federation of AIDS Organisations did some content development, and they have a national network, obviously. So we developed a content map. Then we engaged a digital agency, did a wireframe build. We got a community designer, so someone from the LGBTI community who understands how to market and how to communicate directly to the community. And then we fed that back to the digital agency to do the content creation. And that is how TouchBase was created. And I guess this is just a snapshot of the homepage and the buttons. So if you've got some time after, I'd really recommend checking it out. We're about to also add a whole range of new content over the next 6 months around people's stories. So it's really important that the use of personal stories and narratives are really useful in helping people engage and feel connected to someone else's story, so that there's a sense of hope, but also trying to measure and learn how do their behaviours measure against someone else's. And it's that kind of peer-to-peer education that can really help in drug situations, in drug-taking situations. So I think it's important that we're able to feed a lot of that information through this website. So it always has the clinical knowledge, the harm reduction strategies balanced with lived experience and stories. So this is a section, if you were to go onto the meth page and click on living with HIV, if you were HIV positive, it would tell you that there's a negative interaction with particular HIV medications and methamphetamines. So then that's because of the way that meth is processed. It slows down the metabolism, slows down the process of slows down the timing of processing the drug through the system. It's caused by also using this HIV medication that people might think that they are ready to top up again, but they're actually not, and it can actually be fatal and cause an overdose. So it's really important that we engage with our communities and let them know that if they are using certain drugs, be aware what other medications are they on and how might that interact with the drug. So throughout this website, we also created a range of videos and tools that we invited peers, harm reduction workers, alcohol and drug workers, community activists to speak about their experiences or their views around what alcohol and drug use is, a range across of topics. So that might be what is a therapeutic group, what is a peer support group, what are the signs of problematic alcohol and drug use. And Sally, if you don't mind, maybe we'll just go to that video now.
How would someone know if alcohol and drug use has become a problem? I think that's really for a specific person. Usually when you start losing friends or acquaintances or family, they start moving away from you. They start mentioning stuff to you around your behaviour.
Another way you might find that your usage is becoming problematic for you is how it affects your work life. If you are going to work coming down,
Okay, go back to the presentation. And I did see some notes from people saying that they found it difficult to hear it. Where Sally said that she'll send a link out, but also if you go to touchbase.org.au, there's like 11 of these videos covering different topics, and they're really useful tools. So I'm just really getting towards the end of the webinar now, and going to talk more about specific programs that VAC has developed. Obviously, we have a high percentage of our client base is men who have sex with men who are using methamphetamines. So we've developed 2 programs to work with these communities using these drugs. And one is called Rewired, which is the Rewired Therapeutic Group, which I facilitate with one of my colleagues. And we also have the Rewired 2.0 Peer Support Group. So the Rewired Therapeutic Group, that's a closed group where we assess people in advance and make sure that they're suitable for the group. And we do a range of assessment tools, an audit and a DUDIT and a K10 and a personal wellbeing index, and we work out whether or not they're able to participate in the group. If they are a daily user, it might be that they might need to have one-on-one counselling before they're able to come into the group, because we're quite strict about not being substance affected while coming to the group. And that runs weekly, so for 6 weeks. And that's a CBT-based group. We run through a range of activities and get the group working together to work towards their goals. And that's had some good outcomes. That was evaluated also by the Burnout Institute. And we run that group as regularly as possible, because there's actually waiting lists to enter that group. And in the meantime, if they're waiting for that group, they can access the Rewired 2.0 Peer Support Group. So we put a call out to our community saying, is there anyone out there who is a man who has sex with other men, who has a lived experience of methamphetamine use, who has ideally recovered or has their use under control? And we actually were really lucky to be contacted by a number of people who are mental health nurses, counsellors, alcohol and drug workers, who have a history of methamphetamine use, who are really keen to give back to the community. So Rewired 2.0 Peer Support Group is a really rich, valuable group for the community that runs fortnightly, and it's an open group, so people can come and go as they need to. They are assessed by one of our workers before they enter that group. Again, we have to make sure that they're suitable for the group, that there's no risk of violence or any other kind of illegal behaviour. But that group that's run on the Smart Recovery model. So we put all the peer facilitators through peer facilitator training. I mean, we've been lucky that a lot of them already had a lot of experience, but we utilise the Smart Recovery model. And that's really around behaviour change, and it's around goal setting and working towards changing your behaviour to achieve those goals. So we offer these 2 groups side by side, as well as one-on-one counselling. And if people aren't suitable for the group, then they can do a similar program in one-on-one sessions. So if anyone is interested in looking to develop programs similar to this, please feel free to get in touch with me. I can support you to develop a similar program, or we could perhaps share our resources. If you feel like you've got community members in your area of the country, you think that alcohol and drug use is an issue for the LGBTI community, we also have a group called Drink Limits for lesbian, bisexual and queer women who experience issues with alcohol and anxiety. And we've also run groups for trans people who also have alcohol and drug issues. So we have a range of groups available for the community in this area, and I'm happy to talk to anyone about that. So that really brings me to the end of the session. So if people have any questions, feel free to type them to me now, and I'll have a stab at answering them. Otherwise, my contact details were at the start of this webinar, so feel free to send me an email, and I can certainly help you out at another time. Yeah, so someone just asked a question about the trans programs. So in the alcohol and drug service, we've run a group called Transformed. So that group worked with people's mental health, lack of social connection, and their alcohol and drug use. So that, again, that was also it's like motivational interviewing, CBT based, and goal setting. So what we found with that group is that it was really important to create an intentional space that was trans only, run by trans facilitators, and then you could really get some rich experience and learning from that group. And there's a need for that to continue. We also have Equinox. Equinox, which is our gender diverse health centre, which offers GP services, sexual health services. It's run by transgender diverse people, so I think it's really important where you can to engage transgender diverse people to be running these services. It gets better outcomes. Another question: does the drug usage research apply to older? Yes, it does. The drug research that I talked about earlier, I referenced earlier, the age groups. If you look into the specific data sets, you can see the different age groups. But if I was to talk about gay men living with HIV who are using meth, it's actually men that are in their 40s and 50s that are most likely to be using it. So we are seeing drug use still being quite prevalent in people in their 40s, 50s, and 60s. So whilst they might not be accessing clubs and partying, they're still certainly having private parties or having problematic drug and alcohol use, perhaps on their own. So, the research does cover and span across all ages. Some of the research might be specific, like some of the research might be youth specific, but it does affect all people. So, see if there's any other questions come through. Don't be shy. No worries. Yeah, so another question just came through. Are there specific therapeutic interventions you have found noticeably useful when working with LGBTI community? I think it's really important to be looking at trans affirmative and gay affirmative practice. So that's, I think actually one of my colleagues, Kieran O'Loughlin, did a webinar on this about a year ago actually. So maybe Sally can send a link out to that one as well. So you can certainly also narrative therapies, working with people and their history and their stories. But certainly if you can adopt a trans affirmative approach and a gay affirmative approach, not looking at gay or trans as a deficit, not trying to view it as though there's a negative reason as to why someone has ended up being trans or gender diverse or gay or lesbian or bisexual. More so referencing that as a positive for their lives, and not often people can think that the reason why someone might be gay or trans is because something significantly awful has happened in their childhood, and I think it's important to move away from that. Any other questions? Use comorbidity. We certainly do look at co-occurring, mental health issues when working with our alcohol and drug clients, but that work's probably done more on a case-by-case basis with the alcohol and drug counsellors, and depending on their situation. So hopefully that answers your question with that. I can't speak to that because I'm not actually a counsellor. No problem. Okay, any other questions? You're welcome. If you wanted to speak to someone, one of our counsellors, about specific work like that, I could arrange for that as well. So if anyone wants to talk to someone who has one of our counsellors who has like really rich client experience with, or you want a case study shared with you around how to approach working with a particular client, let me know, and we can provide some secondary consultation, and we can support you with a client who might be LGBTI, who's experiencing either mental health or alcohol and drug issues. Also, if you're in Victoria and you think that you would benefit from some training, VAC also provides training to alcohol and drug and mental health and social services. So feel free to email me and I can come out anywhere in Victoria and deliver training to your service. I feel like the questions have almost reached. I think that's it.
Beautiful. Thank you so much, Jeremy. That was an amazing presentation, and it was really great to delve into different spaces we really haven't had a chance to do that before. So thank you very much. I will share the recording from this presentation and also record the URL for the YouTube video there as well. So I'll do that in very shortly. So thank you very much for coming along today. Please contact Jeremy if you have any other questions. I'm also just going to share a copy of the slides. So I've just shared a downloadable link into the chat box there. So if people want a copy of the slides, you can click on that link and download a PDF of the slides that Jeremy had today. Awesome. We'll have our next webinar in about 3 weeks' time. Our next webinar is actually going to be looking at people with autism spectrum disorder, LGBTI people with autism spectrum disorder, and their experiences of mental health. So again, a really interesting topic to delve into. I'll also put the slides up on the Knowledge Hub as well. To make it easy for people to download. So I will do that the next day or so, perhaps early next week, to give me a little bit more time to get on top of things. So thank you very much. Please contact Jeremy or myself if you need to have any more questions answered, and we'll see you back here in a couple more weeks. So thank you very much for joining us.
Thank you.
Thanks, Jeremy.